So first question is that from this cardiovascular system or acute coronary care domain, 46-year-old man with atrial fibrillation, hypertension, hyperlipidemia, and diabetes is admitted with unstable angina. He undergoes coronary angiography, which demonstrated 90% stenosis of the mid-left circumflex in a left-dominant system. A single drug-eluting stent is deployed with an excellent angiographic result, and patient is given aspirin and ticagrelor. The patient is admitted to the cardiac services. Shortly after arriving to the floor, he reports new onset chest pain. 12-lead ECG is performed, which is in front of you. So question I will first show, then I will show the screen again of the ECG. Which of the following is the next best step in the management? IV nitroglycerin, observation, urgent repeat coronary angiography, transthoracic echocardiography. This is in front of you. What is your take? So I got 2 or 3 C and D. Okay. Kamlen Shukla and Dinesh Ji. D. So what is your diagnosis? What are dealing? Patient had
fresh MI, sir, inferior wall MI.
Sorry?
Sir, fresh MI.
Fresh MI. So already angioplasty is done. And if you are suspecting fresh MI, what will you make a diagnosis? Stent thrombosis.
Stent thrombosis.
Yes, stent thrombosis. So whenever you have done angioplasty, and if patient has again the symptoms and symptoms of chest pain and ECG changes of the MI, then definitely you will say this may be the stent thrombosis. So stent thrombosis is not very common, but it is serious complication in around less than 10% of the cardiac death following stent placement. So this line is very important. This is not so common, but serious complication. And it occurs within first 30 days of the placement and independent of the stent type, whether it's a drug-eluting stent or it's a bare metal stent. The stent thrombosis is common in both types of the stents. Okay, and presentation is same, like ST segment elevation along with the chest pain and other symptoms. Then second question, 55-year-old male with known coronary artery disease with prior PCI, right coronary artery, 2 years prior to presentation, hyperlipidemia and hypertension, present to emergency department with 2 days of exertional chest pain with culminated in acute onset of stabbing substernal chest pain radiating to left shoulder. Temperature is 36.3, blood pressure 200/89, heart rate 81, respiratory rate 18 per minute, saturation 93% on room air, and cardiac troponin T that is undetectable. 12-lead ECG demonstrate normal sinus rhythm, Q wave inferior lead, and non-specific ST segment changes. X-ray showing this thing. So you X-ray in front of you, and what is the following most appropriate next step management? Coronary angiography, CCT of the chest, pericardiocentesis, transesophageal echocardiography. So what is your take? So I have got 2 answers. C, pericardiocentesis. Basically, you are suspecting there is a tamponade. Eh? Why tamponade? In tamponade, you will get hypotension or hypertension. You can unmute yourself and discuss if you think like that.
Hypotension.
Hypotension. So BP is 200/89. Is in the favor of cardiac tamponade?
Aortic dissection.
Maybe. This is the right answer. Aortic dissection you should think, because the stabbing substernal chest pain radiating to the left shoulder. This line is very important. Whenever you find this type of pain, chest pain, which is going to back, you have 2 DDs in your mind. One is acute pancreatitis, another is the aortic dissection. So this is not the clinical setting of the acute pancreatitis. So this may be a clinical setting of the aortic dissection. So if you are suspecting widening of the mediastinum on the chest X-ray, and in history they are giving stabbing substernal chest pain radiating left shoulder, BP is high, and MI is not favorable because this cardiac neuropathy is undetectable, non-specific ST segment changes. So this the most likely diagnosis in this scenario is the acute aortic dissection, and for that purpose you will go for the CT chest, CCT chest. So pain, hypertension, widened mediastinum, and pericardial effusion must prompt a consideration of acute aortic dissection. Okay. So I'm not going in much detail of this aortic dissection because this is the very high yield topic of the exam. So in exam, they will definitely ask at least 1 or 2 spotters, or in EDIC 1 exam or EDIC 2 exam, they will definitely ask from this topic, aortic dissection, especially classification of aortic dissection, type A, type B, Stanford 1, 2, Stanford 1, 2, and the complication of the aortic dissection is the most important question they ask. So rupture into pericardium, acute MI, aortic insufficiency, mesenteric ischemia, lower extremity, stroke, differential of the blood pressure 15%, paraplegia 1%, renal ischemia 8%. So these are some complications depending on the site of the aortic dissection. Okay. So you should read this topic in detail, acute aortic dissection. Then 66-year-old male with hypertension and hyperlipidemia presents substernal chest pain, and ECG is showing inferior ST elevation with reciprocal changes in high lateral leads. So whenever ST elevation, 3 things come in your mind. One is benign early repolarization, another is myocardial infarction, and third one is acute pericarditis. So ST elevation with reciprocal changes, MI. ST elevation without reciprocal changes, especially in a young male patient after exertion, like in gym or weightlifting, there most probably the option will be, correct option will be BER, benign early repolarization. And if they are telling the thing like patient has chest pain which is worsening with the change in the position and pericardial rub, they are, and with ST elevation, then you should think about the acute pericarditis. So these are basically 3 DDs should come in your mind whenever you get the ST elevation. So in this case, they are saying ST elevation with reciprocal changes, so it might be MI. Emergent coronary angiography is pursued with PCI undertaken on a subtotally occluded right coronary artery. Aspirin, ticagrelor, metoprolol, atorvastatin initiated. Patient shifted to ICU, and 12 hours later, patient develops subacute significant shortness of breath. Patient oxygen saturation is 99%. Physical examination is unremarkable. Repeat ECG unchanged. Contrast CT of chest is negative for pulmonary embolism. Which one of the medication is a culprit to this dyspnea symptom? Aspirin, metoprolol, ticagrelor, atorvastatin. So there is a very clear-cut prediction with some drug to the shortness of breath. So the answer is C, ticagrelor. Okay. So ticagrelor is a reversible and direct-acting oral antagonist of adenosine diphosphorase P2Y12 antagonist, and this drug is more commonly used than clopidogrel nowadays. But there is a dose-related episodes of dyspnea even in 14% of the patient. This is a huge number. So if you find dyspnea in a patient who is on ticagrelor, P2Y12 inhibitor, then this is maybe this can be due to because of this ticagrelor dose-dependent dyspnea, which is sudden and unexpected air hunger or unsatisfied inspiration. Like symptoms should be there. So you should have very high suspicion of index when you are using ticagrelor in this clinical setting. If patient comes to you with episodes of dyspnea. So next question. A 65-year-old female with hypertension and hyperlipidemia develops substernal chest pain with dyspnea. Physical exam is notable with the following: BP is 126/62, pulse rate is 76, saturation 97%, sitting up with increased work of breathing, heart rate regular 3 or 4, If 3/6 hollow systolic murmur is heard at the cardiac apex, non-displaced or chest palpation, lung posterior diffuse crackles, soft, non-tender, non-distended, extremities are warm without edema. ECG is showing this thing. So, what is the most likely mechanism of the patient dyspnea? Pulmonary embolism, mitral regurgitation, LV systolic dysfunction, and cardiac tamponade. There are two things are very important in this question, which are very much notable. So you have given answer, just I have to see. B, okay. What was the B option? I should see MR. So rightly said MR, because this is a complication of the MI. So in the complication of MI, there is a mnemonic given in the Washington Manual of Critical Care. That is a, what is the mnemonic? I think this is the failure. Sure, but you should read in the Washington Manual. There is a mnemonic of the complication of the MI. In this, there is a aneurysm, there is a rupture, there is a recurrent MI, there is a embolism. So there are 4 or 5 things which are most commonly seen in the post-MI phase. So you should read more about the complication of the MI. So definitely they will ask question from the complication of MI, and this is the same question. Basically, they are asking about the complication of MI like MR. And in MR, the important feature is the hollow systolic murmur at the cardiac apex. So that's why it's a mitral regurgitation. So ST segment depression in the right precordial leads V1 to V3 with prominent R wave, and the hollow systolic murmur at the left sternal border with pulmonary edema. This goes in the favor of mitral regurgitation. Then 96-year-old female is admitted to the ICU for closer hemodynamic monitoring following uncomplicated deployment of a drug-eluting stent to the first obtuse marginal via the left radial artery in context of presentation consistent with ST elevation MI. 4 hours post-procedure, patient developed acute hypotension necessitating vasopressor support. ECG is performed. And compared to her post-intervention electrocardiogram, ST elevation in lead 2, 3, AVF, V5 and V6 persistent but are less prominent. There are no significant changes. Assessment left radial access site is unrevealing. What is the best next step in the management? Repeat diagnostic coronary angiography, urgent surface echocardiogram, CT imaging of the abdomen, right heart catheterization. So what are you thinking? So answer is C. Okay. So what are you thinking? Post angioplasty, 4-hour patient develop hypotension and patient needs vasopressor support. And this is the ECG. What is your take?
Stent thrombosis again.
Stent thrombosis. Okay. Any other thing?
Inferior wall.
So there are 3 or 4 things which in this situation. One is maybe cardiac tamponade, access site complication leading to bleeding, in intracoronary artery complication like vessel dissection, stent thrombosis, stent migration leading to left ventricular dysfunction and impaired cardiac output. So basically in this situation, they have already given that access site is normal. So access site complication is not there. So in the absence of access site compromise, you have to choose between these 2 things. One is cardiac tamponade, another is like intracoronary artery complication. So you have to go for the transthoracic echocardiography to see the pericardial effusion and mechanical complication of myocardial infarction. Coronary artery perforation is a rare complication, but can occur in less than 1% of the cases. And perforation can be caused by a wire exiting a vessel or by compromise of the vessel wall by a balloon or stenting. So most cases of perforation identified intraprocedurally, but 13% of the cardiac tamponade can be delayed and occur within 24 hours after the departure from the cath lab. So coronary artery perforation may be there, and that lead to the cardiac tamponade. So you should think in, although it's a rare complication, but it can occur. So basically, after angioplasty, three things come to your mind if patient has hypotension. One is cardiac tamponade because of some cardiac artery perforation, coronary artery perforation, excess site complication, which may lead to bleeding and hematoma formation, or intracoronary artery complication like coronary artery dissection, stent thrombosis, and stent migration. So if excess site is normal, then go for the transthoracic echocardiography, which will give you information regarding the cardiac tamponade or any other leading to left ventricular dysfunction. Okay, so this is very important to understand. Basically, in the exam, EDIC 1 exam, you will find most of the questions related to the complications, either complication of acute pancreatitis, complication of the MI, complication of the post-procedural intervention, complication of the aortic dissection. So you have to focus on the complications of the any important thing. So definitely they will ask, procedure has done, and after the procedure patient develop hypotension, patient develop shortness of breath. What will you think? So they want your knowledge of that particular topic, like SAH. So they definitely focus on the complication of the SAH. They focus on the complication of the MI, complication of the aortic dissection. This don't ask simply a question whether you will recognize there is aortic dissection or not. They will not ask this question. Usually in the EDIC 1 type of exam, they will ask the complication of the common things like these pulmonary embolism, MI, SAH, aortic dissection, acute ischemic stroke, or status epilepticus. So they would ask definitely the complication part. So you should prepare in that way. That's why I'm giving this type of question so that you can understand.